I want to thank you, Kyle, for joining me here today, and I would like to give you an opportunity to introduce yourself for our audience.
Yep, my name is Kyle Fredette. I am a local non-for-profit board member, very involved in local HFMA, HIMSS chapters, and within the local healthcare and Mid-Atlantic community.
So the question I'd like to ask you is, what are the top three things that you see hospitals doing to try to either conserve cash, raise their cash on hand, or to make themselves, with a better operational margin, a more positive operational margin?
Yeah, I mean, it's been an extremely challenging market for health systems from a financial perspective. Non-for-profit healthcare systems are filled with a lot of folks who have great objectives to provide care and provide quality of care for individuals. But as you can imagine, the pandemic greatly affected their ability to do that, and a lot of folks left the industry. So I think number one has been the increased cost of labor and having to use travel nurses and having to use labor outside of their environment at a much higher rate. Like a travel nurse will sometimes cost a health system $150 an hour.
Yeah.
And it's not like a health system can no longer have nursing at the environment. They have to have it. So what you've seen is a lot of health systems that budgeted their revenue here and their expenses here, and because of the cost of additional labor, their expenses went here. And so that's been a big challenge for a number of health systems, both small health systems and large health systems. I think another major challenge has been the cost of their supplies. So supply costs, if you think about all the little things a health system needs to operate, you think about the syringes, the Band-Aids, the bandages, the lights, like there's so much capital in the health system. It's a very capital intensive business. And I think that the cost of those supplies have also been much higher than they anticipated. And I think the third major challenge for most health systems has been the cost of their information technology, specifically along the electronic health record. Folks aren't always aware of the cost of some of these information technology, electronic health record projects, but it's not unusual for like a larger health system. Let's say you have one major health hospital and probably 5 or 6 ancillary hospitals. You install, let's say, a health system like Epic, the cost can be over $1 billion to the health system, just to get an idea.
That's the capital cost, and then there's the operational cost of maintaining it every year, which generally runs 18 to 20% of the original capital outlay. Are you seeing that as well?
Oh, yes, absolutely. And it increases the amount of people they have servicing the system that they have to have as FTEs to do that. The cost of these electronic health records are exorbitant, and the reality is that there aren't that many to choose from if you're a health system. I mean, it used to be where you had health systems were a lot smaller, and you probably had 5 or 6 systems you could look at. Really, for most health systems, it's almost a Boeing Airbus kind of thing, where you're looking at either Epic or Oracle/Cerner, one or the other.
It's a two-horse race.
Right, absolutely.
Yeah. So you mentioned the cost of labor, and that's something in every conversation that I have with every C-level of at health systems that we work with, CNOs, CIOs, CEOs. The cost of labor comes up again and again and again. And you mentioned the cost of travel nursing, and some of that I think is starting to evolve because there aren't that many travel nurses to go around anymore, right? And what I'm hearing from a number of CNOs is where, the original strategy to manage labor, having enough labor regardless of cost, was to try to hire as many nurses as they could, whether they're new nurses, whether they're nurses that have been in the field for a while, whether they were travel nurses. And what they're realizing is they just can't hire enough nurses. So what they're looking at is putting technology around the nurses to create a support structure for those nurses, like virtual nursing concepts. Are you seeing hospitals coming to your organization looking for financing for alternatives, technological alternatives to the nursing crisis, such as virtual nursing concepts or sitters, or however they want to describe it?
Yes, I think the health systems really have to be creative with how they're deploying, or how they're providing care. non-for-profit health systems typically are not the most innovative organizations. They tend to have a tried and true method of providing care, and that's worked well for them. However, they've been kind of hit by the perfect storm over the last 4 or 5 years, which has required organizations that typically have been kind of a little bit more didactic in their thinking to kind of have to look at different solutions. And I think technology is an area that you mentioned that they certainly should be looking.
So are you seeing them making more investment in technology in different ways than they used to? Are you starting to see that happen?
Yes, but it's also, they have the challenge of not necessarily having the same amount of capital available that they used to. So they're definitely, the more forward-thinking organizations are. Some are kind of a little slower to adapt, I think. But I think the more forward-thinking organizations, non-for-profit health systems, are looking to technology as a way, because they have to streamline their costs, and they're a very employee-heavy organization.
And how do they think about the return on investment of where they spend their technology? Do they have some hard and fast rules around how they think about that?
It's certainly part of their evaluation process. I think it's going to be really hard for health systems to adopt projects when they don't have a clear ROI, because what you have is you have a lot of different projects that health systems are looking at, but you have a smaller pool from them to pull from. So I do think that creates a challenge, but the ROI is a key part of that discussion.
I know I'm seeing more and more consolidation of health systems. How does that affect how they think about their capital spend and their operational spend as they consolidate systems across, oftentimes regions and then broader geographies?
Well, I think health systems are really looking for economies of scale as they get bigger. And they're looking to consolidate and standardize across certain platforms, and then develop processes upon those platforms and that equipment so that they can maximize the return on those investments. They don't have, as opposed to having a lot of smaller projects per individual hospitals now, what you see larger health systems that have either worked with the GPO or their supply chain group that are going to have a formal process of evaluating what kind of equipment they want to deploy across their entire platform, across health systems. And I don't think that's an overnight thing, because it's an evolution from the healthcare industry, which traditionally does not evolve very quickly. It tends to be a laggard when it comes to technology, but I think they're trying. I think you're seeing systems that are trying to improve their economies of scale and improve their supply chain operations.
Yeah, so the standardization comment I think is really important. We're starting to see more and more standardization in our customer base as well, where they are standardizing across facilities, across the health system. But it is an evolution. It doesn't happen overnight, and it takes time, oftentimes years, before they get to the standardization point.
Absolutely. I mean, the thing about the healthcare industry is it's a very serious industry where you can't make mistakes, right? You have to be very cautious when you deploy technology. It has to work. You have people's lives in the balance. So the adoption of technology and improving economies of scale is a very important thing, but you can't sacrifice patient safety in the meantime. So you really have to have a process of making sure you emphasize patient safety while at the same time continuing to improve the economics of your use of technology.
Last question from me. You talked about, your organization is headquartered in West Virginia. And I know, from my personal experience, there are a lot of critical access hospitals out there, smaller rural hospitals, and they seem to be hit really hard, not only by, COVID and post-COVID and supply chain and labor costs, and we're seeing a lot of critical access hospitals close down. How do you see that in your business? And is there a path to success for critical access hospitals in the environment going forward? Because this is very different than we had pre-2020.
I think it's tough. I think I have to think the critical access hospitals have to be really well run, because most folks don't think about the healthcare industry as a competitive environment, but it is.
Yeah.
And so you have a critical access hospital that's competing with larger health systems. They're not going to have the same amount of services. They're not going to have the same technology. They're not going to have the same equipment. So it's a challenge for them to be able to compete, because they have to, per regulation, have certain levels of technology, which is very expensive And they have to have physicians that are willing to live there, and they have to have staff that are willing to live there. And especially if they're in a geographic area where the population has shrunk because there are less overall jobs or occupations there, it makes it challenging. So it's not impossible, but I think it's harder than it used to be, especially when you see the centralization of care within these larger systems.
Do you see virtual technology, and it could be, you know, telehealth, it could be virtual nursing, it could be any number of virtual approaches to supporting those critical access hospitals with skill sets of, you know, specialists, for example, that live in the larger population areas and don't live in the critical access areas?
I think that's a really good idea for health systems, for these critical access hospitals to look at those kinds of solutions, and they should be looking at them. It depends on, frankly, the management teams of the critical access hospitals. If they're more innovative, or if they're maybe newer to that health system, they may be looking for ways to solve problems that they've identified when they have walked in and taken that responsibility. If that management team has been there for a long time and feels it may be a little harder to get them to change. But I think it makes a ton of sense.
All right, thank you.